Yeah, so I'm Dr. Dayan, one of the pediatric cardiologists at UC Davis. Work closely with all the teams there, and like Dr. Jawar said, you know, heart and lungs, we're neighbors in the lungs, and we happen to pick the same PowerPoint design theme too, so that's great minds. So I'll be talking about cardiac dysfunction and Duchenne muscular dystrophy, which some of you might be a little bit familiar with, and we'll get to some of the details about that. A lot of sort of the mechanisms of cardiac failure and sort of standards of care. So, you know, there's lots and lots of papers out there on heart dysfunction and muscular dystrophy. These are some of the more recent studies that I sort of took the guidelines from. So, talking about the natural history and sort of the progression of cardiac dysfunction in muscular dystrophy patients, sort of starts out with the absence of dystrophin and sort of abnormal cardiac cells, cardiac myocytes, that leads to cardiomyopathy. And cardiomyopathy, that word means abnormality of heart muscle cells. And then what happens is basically they're strained, they stretch out, they don't function normally, and it leads to these muscle cell death, and the cells turn into fibrotic cells. The actual muscle cells that used to contract for every heartbeat turn into scar tissue basically, and fibrous tissue, and then stops working. Fibrosis, you can see in the MRI pictures over here. The heart muscle should, in these types of MRI sequences, should look sort of dark and black, and the blood in the middle of the heart looks white, and you see that sort of white line in the middle of the black on the outside, and that's scar tissue that's not moving during cardiac function. Sometimes this can be associated with early changes on the EKG, which is why we do EKGs on all patients, electrocardiographic changes, and predominantly in a lot of studies, you see these fibrotic changes before you see dysfunction by echo, looking at the actual ejection fraction and things we look at for cardiac function. But it's really difficult to predict the onset and progression of this in different patients. That fibrosis leads to what we call heart failure. And heart failure is basically an inability of the heart to eject blood to the body and meet the body's tissue demands. There's an echocardiogram of a heart with the left ventricle that's not pumping very robustly. And then that can lead to arrhythmia. So the heart muscle has scar tissue in it, and the heart isn't functioning very well. The muscles aren't aligned appropriately, and there's arrhythmias, heart rhythm issues, the heart not pumping, not conducting in the appropriate manners. And those arrhythmias and the heart failure are ultimately causes of death in these patients. 20, 30 years ago, a lot of muscular dystrophy patients, their mortality was predominantly from respiratory issues, and Dr. Jawar and his colleagues really ramped that up with non-invasive and nocturnal ventilation, things like that. So now, these patients are living longer, but primarily, their cause of death is our fault. Heart failure and arrhythmias is really the end stage, and so that's really a huge question on how can we make that better. If I can move forward. You want me to move that slide forward? Oh, there it goes. So first of all, talking about the pitfalls in cardiac management, why are we missing this? Why are we getting to it late? Why is this such a problem? And this has been shown in several studies. Late referral to subspecialty care. And again, we're trying to address that at these larger centers where we have multidisciplinary clinics and early referral to cardiology, but there's still, a lot of places where you have late referral to subspecialty care of PM&R, but also late referrals to cardiology and pulmonology. Really difficult to diagnose symptoms. The New York Heart Association symptoms are based on ambulation. How far can you walk? How many stairs can you go on? This kind of thing. That's really difficult to assess in our patients that have skeletal muscle abnormalities because their fatigue and their decreased exercise tolerance isn't necessarily from their heart muscle decline. And then it's also difficult to diagnose the objective measures. A lot of times these kids have scoliosis or abnormal chest walls, and it's difficult to get imaging. Again, sometimes if you don't do early diagnostic testing, you can sort of miss that fibrosis or miss the changes on the EKG before you get to that heart dysfunction time frame. Inadequate cardiovascular monitoring sort of goes along with lack of referral to subspecialty care. If there's lack of ongoing follow-up and frequent follow-up and monitoring, that can be a problem. And then late initiation advancement of heart failure therapies. Again, if you're going to see somebody that isn't specialized in heart failure or in specific muscular dystrophy, cardiac dysfunction, they may be more slow about initiating these heart failure therapies earlier on in the clinical course. So the guidelines for heart screening, sort of in this time frame area, is stage 1 at diagnosis. There should also always be a cardiology consult at diagnosis, no matter what the age. In our clinic we see patients very, very young, and I do consults on all those patients, even though we know that the heart dysfunction is not going to, progress that early. We get a baseline EKG to see how things change over time, see that early fibrotic changes in the form of the electrocardiographic monitoring, and then early echo and MRI, again, to see how things change. And sometimes we start medication on kids whose heart function is normal but has declined. Normal ranges are based on population studies, and every patient's a little bit different. So it's important to do that baseline cardiac assessment of EKG, echo, and sometimes MRI. And also for consultation and sort of explaining to families and patients what this cardiac dysfunction is, what it's going to be, how it potentially progresses, and sort of getting the education on that early on. And then in the early ambulatory phase, annual functional assessment is recommended, again, with EKGs and echoes every year, sometimes every 2 years if they're very, very young, but typically annual assessment. And then really initiating therapy for heart failure by 10 years of age, regardless of heart function. That's really been shown to sort of delay the onset of progression and slow down that progression. And then later on in the disease process, at least annual assessment. If anything's wrong symptomatically or on any of our studies, then we do every 6 months, every 3 months, every month even. But at least annual in the non-symptomatic and seemingly normal patients. And then we monitor the cardiac rhythms, again, with EKG at every visit, but then we do, every year or two, we do a Holter monitor, which is like a 24-hour EKG. And then you advance the cardiac therapies as indicated. So one of the big questions that I get a lot, and big questions in the literature out there too, is, do we monitor with echo or with MRI? And both the tests have sort of their pluses and minuses. They both look at left ventricular, left pumping chamber systolic function very well. And systolic and diastolic function is interesting too when we talk about heart failure. It's sort of a newer concept in the past 5 to 10 years or so, at least in pediatric cardiology, of systolic function is the squeeze of the heart, and diastolic function is the relaxation of the heart. And for a long time, the relaxation of the heart wasn't really well recognized as an important factor in heart function. It was, the squeeze of the heart, the ejection fraction, how much heart is the blood pumping. But the relaxation of the heart is very important so that you can actually get blood into your heart to eject it. So we look at systolic and diastolic dysfunction. MRI is probably a little bit better at looking at quantitative right ventricular systolic function than echo. Both of them can do what we call speckle tracking strain analysis, which is, I'm not going to get very much into, but it's basically looking at every pixel on the picture of the heart and looking at how almost how each heart cell moves and the velocity of movement, and that is a sort of a different way to look at the systolic and diastolic function. Echo is relatively cheap and MRI is pretty expensive. Echo is all over the place and pretty easy to do bedside. MRI is less prevalent and may require sedation. Sometimes it's hard to get kids into the machine, kids and adults into the machine. And then down at the bottom there, poor acoustic windows in echo. So again, older kids with scoliosis and sort of scarred or thickened chest walls, sometimes it can be harder to get the images. And with cardiac MRI, none of that is really an issue. And cardiac MRI looks at fibrosis, that fibrotic change. In that picture I showed earlier, you don't really see that by echo. So again, I think in our clinic we do mostly echoes, and our cardiac sonographers are really, really good, even in difficult patients, of getting the optimal windows to look at this heart function, systolic and diastolic heart function. But more and more, we're considering doing MRIs in these patients to sort of see earlier fibrotic changes and seeing in patients who are hard to see those structures looking at MRI. So again, the screening is at least annual. We do a history and physical exam, and again, the history, asking about chest pain and difficulty breathing and fatigue and all that can be difficult to sort of attribute to heart muscle dysfunction, but if things change, on a clinical basis, that's important to know. EKG, echo, and MRI. Like I said, long-term EKG monitoring with like a Holter monitor, an event monitor, because a lot of times these kids do have extra heartbeats or arrhythmias that they're not seeing, or they're not feeling, and they're not having symptoms from, but we want to know if that's happening because that gives us an indication if the heart muscle is healthy or unhappy. And then we do risk assessment for procedures. These kids get PICC lines, G-tubes, trachs, all sorts of different procedures, even dental work, and the question is, are they, healthy from a cardiology standpoint to undergo these procedures, undergo anesthesia? And so we do that risk assessment for every patient at every visit. And then, again, multidisciplinary care is really key to this process too. Like Dr. Jawar said and Dr. McDonald, the open communication is really important in our clinic. Each patient that comes in, Dr. McDonald says, oh, what's the ejection fraction today? What are we changing today? What are we, how are we changing our care today? And it's all this group approach and really minute by minute changes so that we can all talk to each other about and really focus our care based on that. So the management and therapy, again, this is taken from the guidelines and hasn't changed a lot in the last few years. The newest guidelines were about a year and a half ago, is to initiate heart failure therapy at age 10. And we start with a class of medicines called ACE inhibitors. And you may have heard lisinopril or enalapril, similar drugs, angiotensin receptor blockers like losartan. What those medicines do basically is lower your blood pressure. And everybody always asks me, oh, is his blood pressure high? Why do we have to lower the blood pressure? And I tell them it's sort of like if you imagine the heart's lifting weights. With every heartbeat, it's like pumping iron, it's lifting weights. The weights is basically your blood pressure. When you lower your blood pressure, it's making it easier for the heart to pump every heartbeat. And so it allows the heart to be able to function more efficiently for longer. And in the studies, it's been shown, it may slow down the progression of that fibrosis and the heart dysfunction and can improve long-term outcomes. And then when we see, older patients with severe dysfunction, when the heart's sort of big and dilated and not functioning very well, that they're at risk for developing thrombus or clot inside their heart and then, ejecting that to their body. So in patients who have severe dysfunction, we start aspirin prophylactically. And then as the patients get older, we start adding other medicines. And some of you that I've seen in clinic, I start with lisinopril or enalapril at a young age, and then as you grow older, I increase the medicine based on, weight and blood pressure and efficacy. And then as we see heart dysfunction, I tend to be pretty aggressive about starting other medicines in addition to try to, again, delay that onset of heart muscle dysfunction and slow down the progression. So I usually start with lisinopril or enalapril and then add on a beta blocker. And the, beta blocker of choice for heart failure in the adult world and in the pediatric world has sort of changed over the years. And my favorite one, and the one that's in vogue now, is carvedilol. And what that does, it's a beta blocker and also an alpha blocker. So it actually slows down the heart rate a little bit, allows the heart to fill a little bit more. It's been shown to remodel the heart, so actually adjust the heart muscle cells to align better and function better, and decreases your blood pressure a little bit. So it does all these things at once, which is really nice. And then that, in conjunction with this group of drugs called mineralocorticoid receptor antagonists, like spironolactone or eplerenone, that's been shown to work synergistically or with carvedilol to sort of realign those heart muscle cells and slow down the progression of the heart dysfunction, which is really nice. And then diuretics I don't use as frequently, but in patients who have extra fluid on their lungs or swelling of their body, things like that, we add a diuretic to sort of pee off that extra fluid. That's sort of the most annoying for patients, especially in the middle of the night. So I tend to sort of defer that for more extreme cases. And then invasive cardiac management is a little bit more controversial and sort of depends on the disease process and it's very patient specific. But adding sort of mechanical circulatory ventilation, basically a heart bypass machine or heart transplantation. So those things can be considered, but it's pretty rare. And then again, looking at the heart rhythms and heart rhythm management, we do EKGs at every assessment and then Holter monitoring. If we see anything abnormal, I basically start medicines pretty early. If I hadn't started a beta blocker by then, I'll start a beta blocker. I'll go up on the dose pretty aggressively. If the arrhythmia burden seems pretty large on carvedilol, I'll switch to a different beta blocker that's better for arrhythmias and still functions well during heart failure. And then, again, consideration for an implantable device. Basically, if somebody has a lot of extra heartbeats and they're at risk for having a fatal ventricular arrhythmia, you can implant a device that would shock them out of it. And then it's a question we sometimes get, what about female carriers with muscular dystrophy, Duchenne muscular dystrophy? And the studies are widely variable, but 25 to, a quarter to 3/4 of female carriers will develop cardiomyopathy at some point. Usually that's older, above 16 years of age. And in some of the studies I read, up to about 50% have some abnormalities. It maybe just fibrosis on an MRI, or maybe their EKG is a little bit abnormal, but not fulminant cardiomyopathy. But there's still, a good amount that will develop that. And so the recommendations are to screen with EKG and echo in early adulthood, 16, 17, 18 years of age, and then surveil them every 3 to 5 years and continue to monitor them. So then, going forward, what are the steps moving forward? And again, I'm going to tout the multidisciplinary team to assess all angles of the patient's clinical care, having better earlier diagnostics, and whether that's with MRI or better echo technology, looking at diastolic dysfunction earlier, whether we need to give medications earlier that will, again, delay the onset of progression of heart disease. And then really patient-specific therapies is the exciting part, and Dr. McDonald touched on this a little bit too. Specific genetic mutation-guided therapy. Do you have, this genetic mutation? Maybe this drug will work better for you. Maybe drugs, gene therapy that work on certain, on the cardiac myocytes specifically will work better for these patients. So that's something, sort of the ongoing research that's happening in the field. And then, these are all within the last 6 months, tons of articles coming out on assessing patients early. What are the pitfalls to getting therapy? What are the new drugs we can do? Advancement of heart failure therapies, different medications. Are there benefits to implanting devices? All sorts of stuff that's coming out all the time that we use to guide our care continuously. And there's, resources for families and providers on the PPMD website, guides for families, all this kind of stuff that sort of summarizes all the stuff I just talked about. And that's it.
And before we jump to questions, I'll just add that guy that he referenced is out at the reference desk if anyone would like to take one home. There's plenty.
Okay.
By any chance, do you see adult carriers? So do you
Yeah.
see mothers? You do?
Yeah, we do, and I won't go deep into it. A question I get a lot in muscular dystrophy clinic and in other clinics is, why are you, as a pediatric cardiologist, seeing adult patients? And there's a lot of different reasons for it, but basically in the muscular dystrophy group, we continue to see them just mostly to have this continued care through early adulthood and middle adulthood with, I basically told Dr. McDonald, as long as you're seeing them, I'll see them. And then female carriers, there's different ways of doing it at different centers. I'm happy to see patients of all ages. The heart failure therapies are pretty similar, and so as a sort of pediatric heart failure specialist, there's not a lot of difference in this management in the adult population, to be honest. So I'm happy doing it and sort of having the care all under one roof. There's other centers that will send, adult carriers to an adult heart failure cardiologist, and I think that's fine as well.
So excuse my ignorance here, but when you say female carriers, do you mean any mother of a Duchenne boy? Is that a carrier?
If they have the gene positivity.
Okay.
So it can be a novel mutation in the patient, or it could have been from the mother. So, yeah.
So this is something they should probably bring up with their primary care? Okay.
Yeah.
Thank you.
They should. And siblings, yes. Yeah, definitely.
Any other questions?
Cool. Thanks.